Good morning, everyone, and thank you for attending this month's preparedness webinar series through the Region 7 Disaster Health Response Ecosystem Grant. Today, we are going to discuss the medical management of chemical exposures with Kathy Jacobitz and Dr. Josh Trebach. So next slide. Just a couple webinar objectives here on the screen and description for today's webinar. We're going to talk about the Chem Specialty Team, recognition, medical management of chemical threats, CHEMPACKs, and other chemical exposures. So next slide. Today's webinar is accredited for the live viewing only for one CEU, and that information will be provided here in the beginning and then also towards the end of the webinar to claim your credit. Disclosure declaration. The next slide. Our faculty have no disclosures, and our planning committee just disclosure for Dr. Lawler. And there's no other disclosures for today's session. Any questions, please put in the Q&A function of the Zoom down on your Zoom functions, and then also anything in the chat. And what we will do is at the end of the webinar, we will facilitate a Q&A session with our speakers. To obtain your CE for today's webinar, you'll go to the website listed on the screen and then type in the activity code 61880, and then you'll be able to answer a few questions and get your certificate. And with that, I'll go ahead and introduce our two speakers today. So first up, we'll have Dr. Josh Trebach, who is a medical toxicologist and emergency physician at the University of Iowa Hospitals and Clinics, and he's also the Associate Medical Director at the Iowa Poison Control Center. He has completed his medical degree from Johns Hopkins University and his residency in emergency medicine at Johns Hopkins Hospital, and then his medical toxicology fellowship training at New York University in the New York City Poison Center. And then he also serves on our Region 7 Chemical Specialty Team. And then after Dr. Trebach, we'll have Ms. Kathy Jacobitz, who is the director of the Nebraska Poison Center in Omaha, Nebraska. She has over 30 years of clinical toxicology and poison center leadership experience. She chairs the OMEC, or Omaha Metro Healthcare Coalition Pharmacy Work Group, and leads the Region 7 Chemical Specialty Team. So with that, Dr. Trebach, I'll turn it over to you.
Thank you very much. All right. So I know that we just discussed some of our the overview of the talk, but here's some of the objectives that we're going to be going through today. So first, we're going to be describing the toxicity and treatment of 4 different chemicals here. We're going to be talking about nerve agents, asphyxiants, irritant gases, and acids. We're going to be discussing the roles and responsibilities of the Poison Center and the Region 7 Chemical Specialty Team and the management of exposures such as these. And then we're going to be discussing the availability of clinical guidelines, CHEMPACKs, etc. If there's any questions, we'll again put them in the Q&A, and then we'll go through them towards the end. All right. So first topic we're going to dive into today is irritant gases. And irritant gases in general are gases that are corrosive and can produce local toxic effects or injury when exposed to the skin, mucous membranes, etc. Their toxic effects are usually after they dissolve in water. And we can see these local effects either in the upper airway or the lower airway. So we can see things in the eyes and the nose and the pharynx and larynx, but then we can also see these symptoms in the trachea and the lungs. And when we think about whether an irritant gas is going to cause in upper airway symptoms, such as in the mouth and the larynx and even on the eyeballs, versus the deeper effects like in the lungs, we classify them according to their water solubility, and those give us a hint as to what system is going to be affected. So for example, here on the left side of your screen, you see something that is highly water-soluble irritant gas. This is ammonia, also called anhydrous ammonia. Ammonia has this, it's a colorless gas that has this urine-like smell. It's a very suffocating smell. Different sources include fertilizers, refrigerants, explosives. It's also used in chemical synthesis and manufacturing. So ammonia is an example of a high water solubility irritant gas. And so high water solubility irritant gases will dissolve in water quite readily, and the first places that these gases come into contact with water are in our eyes and our mucous membranes directly at the sort of the top of our respiratory tract, so in the mouth and the upper airway. Hydrochloric acid is also a highly water-soluble irritant gas. It's often colorless, does have this pungent, irritating odor. It's also called muriatic acid. Sources for hydrochloric acid can be scale remover or metal cleaning. It's also used in ore reduction and in rubber production. And a lot of these have chemical uses as well in chemical manufacturing. In the middle here, we have chlorine gas. And chlorine gas is doesn't have a high water solubility, but doesn't have a low water solubility either. It's kind of in the middle. So it can kind of cause some of these similar symptoms that we can see with some of the high water solubility, and then some of the symptoms we can see with the low water solubility. And we'll get into that momentarily. So chlorine gas, unique about the color of chlorine gas is it has this yellowish, greenish appearance. It does have a pungent odor as well. It's described as like a pungent, suffocating odor. And when the uses that we see for chlorine gas are usually in water purification plants, it's used as a pool disinfectant, manufacturing of PVC or polyvinyl chloride, and different chemical synthesis. So two on the left are high water solubility. Chlorine gas in the middle is a intermediate water solubility. And then on the right here, we have two examples of something with low water solubility. So phosgene gas, this is one of the sort of the classic pictures that we sort of see in the literature and when we discuss phosgene gas. And phosgene gas has low water solubility. It's a colorless gas that smells like, people say, like musty hay or moldy hay. And some people even go as far as to describe this as a potentially pleasant smell, which, you might be continuously exposed to it for a little bit longer, or you might be wanting to breathe it in very deeply because it doesn't smell too bad and can actually lead to some problems. So with the low water solubility agents, they aren't going to really affect your eyes or your upper airway as much because they're not dissolving in that readily available water that's in your eyes and your upper mucous membranes. So they can get down deep into the lungs, and the layer between the lungs and where our blood vessels are, the alveolar capillary membrane, they can cause some damage there. And so we can see patients have pulmonary manifestations like shortness of breath. They can have pulmonary infiltrates on chest X-ray. People can develop delayed acute respiratory distress syndrome. And so sometimes we can say these symptoms are delayed for even up to 6, 8, 12. Some sources even say up to 24 hours later due to the delayed effects from these gases causing damage. And another thing to keep in mind is that if something is directly irritating to your eyes and your upper mucous membrane, such as ammonia or hydrochloric acid, you're gonna be noticing that right away, and you're gonna want to get out of there. But with phosgene gas, for example, or nitrogen dioxide, which we'll talk about momentarily, you might be not as aware of something going on. You might be more continuously exposed, and you might be exposed longer than you would be with something that's a higher water solubility. So the lower water solubility irritant gases tend to be a little bit more dangerous, in my opinion, just because they're a little bit sneakier. So phosgene gas is a military. It's a military poison gas. It's also used in chemical synthesis and polyurethane and polycarbonate production, and it can be a byproduct of combustion as well. In Ohio in 2023, there was that train derailment, and I know that for some of you who are following the news, those of us in the toxicology and the poison center world, we were watching it quite closely. There was some discussion that is there a risk of phosgene gas due to some of the byproducts from the chemical reactions that were occurring. Nitrogen dioxide is a reddish brown color of the gas. It has this acrid smell. We think about nitrogen dioxide a lot for it's an oxidizer, so we can use it. It's used to as an oxidizer for rocket fuels. Also, we think about grain silos and different breakdown products leading to the generation of nitrogen dioxide, which can ultimately be dangerous as well. So I've divided these gases into high intermediate, or low water solubility. And this is the chemical distinction, or the physical exam distinction that we can see when we see patients and work them up. So high water solubility things, such as the ammonia that I had mentioned, are more likely to affect your eyes, the upper airway, immediately irritating and uncomfortable. Lower water solubility things like phosgene, we can see these delayed pulmonary effects. Now, both of them are obviously not ideal. We'd rather have none of these, but usually the high water solubility are going to be more apparent just because of the immediate effects. This chest x-ray is showing a bunch of pulmonary infiltrates, likely consistent with acute respiratory distress syndrome, which is one of the feared complications of these low water solubility gases. So the question is, how do we treat these? Well, first things first is we want to get patients and people away from wherever this gas is. So removal from the scene sounds self-explanatory, but I think sometimes when there's a lot of when tension is high and people are concerned and everyone's trying to do a bunch of different things at once, sometimes we can not appreciate how just getting out of there might be the best thing for people. Okay, so removal from the scene is of paramount importance. When the question of decontamination, this isn't decontamination of like the gastrointestinal tract. Rather, this is decontamination of the skin and getting your clothes that might be contaminated or soiled. Sometimes clothes can trap different vapors. We want to make sure these clothes are removed. If these certain gases can cause a chemical reaction to occur on the skin, and so we would want to irrigate those with copious amounts of water to remove those agents and prevent these chemical reactions from occurring. Oxygen and ventilatory support as needed. Again, if a patient just has some eye irritation, I don't think, and then they're otherwise breathing comfortably and their vital signs look great, I don't think you need to throw them on 100% oxygen and, non-rebreather and blast them with oxygen. I think you can treat each patient individually. Certain people might be more at risk for having flare-ups of their underlying pulmonary conditions as well. For example, if someone has a history of asthma or COPD, they might be a little bit more predisposed to having some inflammation or some reaction when exposed to some of these irritant gases. Other adjuncts that we think about are a little bit more specific to the agent. And again, this is an overview, so we're not diving into every possible irritant gas and the management of every irritant gas, but in general, these are the major sort of treatment strategies, but there are other adjuncts depending on the agent. So, for example, with chlorine gas inhalation, there is some discussion of the utilization of nebulized sodium bicarb to treat the inhalation. And the thought is that you can neutralize the agent and then breathe off the heat that's generated in that reaction. So that's like kind of an overview for the irritant gases. Again, we're going to take questions at the end, and just to make sure that we are being respectful of everyone's time, I'm gonna keep moving. But again, we'll take questions at the end. So that was the first topic. The second category or topic that I want to get into here is cholinergics. And so cholinergics are substances, be it a gas or a liquid, etc., that bind to and inhibit acetylcholinesterase. And what does that actually mean? So if you look at the diagram here, we see on the top, this is a neuron. We see vesicles, those white circles, and inside the vesicles are a neurotransmitter called acetylcholine, or ACH. Now, acetylcholine is a neurotransmitter that's involved in synaptic transmission between our neurons. So it just helps our neurons talk to each other. It helps our neurons communicate with muscles and things like that. Acetylcholinesterase, or which you can see is the green semicircle here, is something that breaks down acetylcholine. So when you inhibit acetylcholinesterase, you are breaking down less acetylcholine, and the end result is you get more acetylcholine, okay? And so if you have more acetylcholine, you are binding to more cholinergic receptors, which are in this diagram, those blue rectangles. So what does it mean if you're binding to acetylcholine receptors or cholinergic receptors? Same thing. What does it mean if you're binding those more? What's so bad about excess acetylcholine? Well, This diagram is meant to demonstrate that there is a lot of things that acetylcholine does. Again, looking on the left here, and then this corresponds with the different manifestations on the right. Just appreciate how prevalent acetylcholine is in communication between these different systems. So, for example, we have parasympathetic actions, sympathetic actions, and somatic nervous system actions of acetylcholine. So acetylcholine has a lot of roles. Now, certainly, when you're treating a patient or patients who have been exposed to cholinergic agents, one strategy is to think about the pathophysiology and remember something like this when you're thinking about the different manifestations and signs and symptoms. But there's a bit of a more straightforward way to do it. Instead of remembering all the stuff you see on the screen here, we divide the cholinergic toxidrome, if you will, into two different categories. So we have our muscarinic symptoms, and we have our nicotinic symptoms. Our muscarinic symptoms can sometimes be remembered by the mnemonic sludge. So you can see the symptoms here spell the word sludge, and then we say the killer bees. So sludge and the killer bees for the muscarinic symptoms. And so you can see that the muscarinic symptoms for patients who are experiencing cholinergic toxicity are fluid essentially coming out from everywhere, was how this was described to me when I was a toxicology fellow. I just said, imagine someone with fluid coming out of every orifice possible, their mouth, their bottom, their skin, everything. So patients are having salivation, lacrimation, urination, defecation, they're vomiting, they're not doing great. But if someone's going to die from a cholinergic toxicity, we think about the killer bees, so the bradycardia, the bronchorrhea, and the bronchospasm. So bronchorrhea specifically referring to fluid building up in the lungs, because like I said, fluid's coming out everywhere. Bronchospasm, impairing someone's ability to ventilate, and then bradycardia sometimes can be life-threatening due to your heart beating so slow you're not perfusing very well. The nicotinic symptoms are sometimes remembered with the mnemonic Monday, Tuesday, Wednesday, Thursday, Friday, just the days of the week. And these tend to cause muscle cramps, tachycardia, weakness, muscle twitching, and fasciculations. And so these two big categories are the cholinergic symptoms that we think about. So acetylcholine does quite a lot. Again, it's one of our neurotransmitters. Too much acetylcholine can be bad, but also too little can be bad as well. This is the case of too much acetylcholine. This very crude diagram is something I remember from, I think when I was in medical school or residency. I remember this popping up and it just got burned into my brain. And now I'm burning it into everyone else's brain right now. It is a crude representation of the cholinergic toxidrome. Again, someone representing fluid coming out of virtually every orifice, in addition to some bradycardia. And then they got a little insecticide on the bottom left corner, which we'll talk about. So when we think about the worlds of cholinergics, two big categories. So there are some other types of cholinergics, but two big categories are insecticides and chemical warfare agents. So diazinon and chlorpyrifos that you can see here are two insecticides that are cholinergic. The picture on the bottom right is to serve as a general reminder that a lot of our nerve gases, such as soman nerve gas, sarin nerve gas, are cholinergics and can be very, very dangerous. And then the top right picture, this is Kim Jong-nam, who was assassinated with VX, which is a nerve agent as well. So I'm living here in the Midwest, and so it's not unheard of to have people who are unintentionally exposed to these insecticides. It's also not unheard of to hear about people purposely exposing themselves to insecticides. We don't see a lot of nerve agents, of course, on a daily basis, but this is something that we always have to be concerned about because a large amount of people can be affected by nerve agents. And when we talk about the treatment, you'll see why that can be relevant. So treatment of the cholinergic toxidrome is first going to be decontamination. Of course, you want to remove patients from the source, and you want to make sure that you are not having secondary contamination of personnel. So we want to make sure that we have appropriate PPE and the staff taking care of these patients, or the team taking care of these patients. And again, removal from the source, copious irrigation, soap, water. Atropine, benzos, and pralidoxine are going to be like the trifecta of how we treat the cholinergic toxidrome. Atropine is a anti-muscarinic agent, and so you can think about how that makes sense if I told you you have all these muscarinic symptoms. An anti-muscarinic agent, such as atropine, is very beneficial. So when we give atropine, we usually say we want to give atropine until you have drying of the respiratory secretions, because most people, if they're going to die from their muscarinic toxidrome, it's usually going to be due to one of these killer bees. And so if you can help control that with atropine, make sure that their respiratory rate's okay, make sure they're perfusing okay, make sure they're oxygenating and ventilating okay, you can use supportive care to get them through it. The dose of atropine is, you can see it here if you put your head close to your screen, but it's a 2 milligram injection. This is a duo antidote kit here. So atropine is the green medication on the bottom there. So we say 2 milligrams, IV every like 2 to 4 minutes, and you can do larger doses. Sometimes a single patient can exhaust an entire hospital supply of atropine. Okay, and so what happens if you have 15 patients come in that need atropine? What do you do? And so this is why we have discussion about stockpiles of antidotes in certain situations, if that ever arises, because like I said, a single patient can exhaust a large supply of atropine. Benzodiazepines are great for stopping seizures, and if those are seen, because cholinergic toxicity can manifest with seizures. And then pralidoxime, again, I can talk forever about pralidoxime, but since this is just an overview of the webinar, I'll say that pralidoxime works by preventing aging of the acetylcholinesterase enzyme. So what is aging? Aging refers to a process by which that enzyme, the acetylcholinesterase, undergoes a conformational change where its inhibition is permanent. Okay, so different cholinergic agents will age at different rates. For example, Soman nerve gas ages very, very, very quickly. Okay, and so if versus other exposures might take a little bit longer to age. So pralidoxime helps to prevent the aging, helps to prevent this process from being irreversible. Again, not everyone has pralidoxime on hand. A lot of places have atropine because that's just used a little bit more frequently for other conditions. But these three medications, atropine, benzos, and pralidoxime, are go-to for the cholinergic toxidrome and treatment. All right, so that was 2 out of 4. Next, we're going to talk about asphyxiants. So asphyxiants are chemicals that interfere with the body's ability to use or transport oxygen. All right, so there are 2 different groups of asphyxiants based on their mechanism. You can be a simple asphyxiant or a chemical asphyxiant. Now, what are the differences? A simple asphyxiant is something that just displaces oxygen in the air. So when someone breathes in air, they breathe in less oxygen because whatever is the asphyxiant is kind of pushing the oxygen out of the way. So something you can think of is like carbon dioxide. So if you were put in a room with carbon dioxide gas, you can think of like from like dry ice or something. That is a way that someone can asphyxiate because the carbon dioxide displaces the oxygen in the air. Same thing with nitrogen gas, which you see pictured down on the bottom right. Nitrogen gas can when breathed in, it can displace the oxygen as well. So they breathe in less oxygen, people can feel short of breath, they can get hypoxic, and then if those symptoms get severe enough, people can lose consciousness. Chemical asphyxiants, on the other hand, interfere with hemoglobin or your mitochondria in general. So they still interfere with oxygen, but although some chemical asphyxiants can do what simple asphyxiants do by displacing oxygen, chemical asphyxiants will either interfere with hemoglobin or the mitochondria. And it depends on the agent. So for example, carbon monoxide here in the bottom left, we think about carbon monoxide as being from incomplete combustion of things like propane or gases, kerosene, charcoal. These carbon monoxide binds to hemoglobin and can impair our ability to carry oxygen. And furthermore, carbon monoxide can have some effects on the mitochondria as well. Hydrogen sulfide in the middle, you see this warning side for hydrogen sulfide. Hydrogen sulfide tends to be used for like chemical reactions and in making metal sulfides, but can be very dangerous if breathed in due to its ability to inhibit the mitochondrial electron transport chain, which you need for standard aerobic respiration, making ATP so your body can function. Hydrogen cyanide here on the right, has some uses in like gold and silver mining and electroplating. It's a chemical reagent, but this can also be a byproduct of the burning of synthetic polymers or nitrogen-containing plastics. So we can sometimes see this in patients who are exposed to certain fires. But hydrogen cyanide, again, similar to hydrogen sulfide, inhibits your mitochondria, your electron transport chain. And so people breathing in hydrogen sulfide or hydrogen cyanide can just suddenly collapse and sometimes even had sudden cardiac arrest simply just due to the downstream effects of the asphyxiant. This is a picture of an individual who is slumped over in their car, and I can tell you that in my work at the Poison Center and in the emergency department, I've taken care of patients who have been just found unresponsive in their car, and I think something that always impresses me is, how there's not always the best discussion about what we need to be doing when we see someone who might be down in an enclosed space, because the question is, what would we be exposing ourselves to? So the classic scenario with someone who is exposed to gas like hydrogen sulfide, for example, is there's someone in a pit or a room collapses and goes into cardiac arrest from hydrogen sulfide. Another person's like, hey, I haven't seen this person in a while. Let me go check on them. They go check on them, they go down as well. And then this process repeats until someone's like, hey, like 20 people have gone to look for Joe. Like maybe something's happened in that room. So we need to be cognizant whenever we see patients in an enclosed area that they might be being exposed to some sort of gas or a poison that can be very, very deadly. And depending on the concentration of hydrogen sulfide or hydrogen cyanide, sometimes even 1 or 2 breaths is enough to make someone collapse, which is scary. So the treatment of the asphyxiants, of course, decontamination, we've been going over. Get out of the exposure, get away from the exposure. If you're being asphyxiated, we want to give patients oxygen. We will do anything to help them ventilate on the agent. So for carbon monoxide poisoning, hyperbaric oxygen or just large, like oxygen on a non-rebreather are 2 different strategies for treating carbon monoxide toxicity. In the middle here, we have some antidotes for cyanide toxicity, hydroxycobalamin. And on the bottom, we have a picture of something called our Lily kit, which is something we can use to treat cyanide as well. And on the right here, we have methylene blue, which can treat methemoglobin, which can be caused by some other agents as well that you can inhale or be exposed to. Different asphyxiants. So again, the treatment depends. Some of the specific antidotal therapy will depend on the agent, but in general, decontamination, focusing on oxygen and ventilation is of paramount importance. And the last topic that I wanted to just give an overview on are the corrosive acids. So what is a corrosive acid? Well, it's basically anything that is destructive to exposed tissue. So in the case of acids, destruction of tissue occurs via a process called coagulative necrosis. It doesn't sound good because it's not good. And I'll show you some pictures. The exposure routes can be on your skin, it can be inhaled, it can be ingested, a lot of different ways to be exposed to these. And some examples of corrosive acids include the 4 that you see here: sulfuric, hydrochloric, nitric, and hydrofluoric acid. I put a little asterisk next to hydrofluoric acid because in addition to being a caustic or a corrosive acid, hydrofluoric acid also can do some unique things, such as causing a local hypocalcemia. And I'll show you some pictures of that. I do have some pictures of these burns, just as a forewarning for people who are watching this. If that's something you're not interested in seeing, just now would be a time to minimize me. But I'm just gonna be showing you some pictures. All right, so This is a picture of a sulfuric acid burn. And sulfuric acid, again, I like reminding people that a lot of these agents have uses outside of just being used to harm people, which is why a lot of these agents exist. So, for example, sulfuric acid is used in the industrial production of chemicals. It's a industrial cleaning agent that's used to remove like oxidation and rust and scaling. It's also a catalyst. But you can see that the shear breakdown of the skin, you can see when someone's exposed to it. Now, if someone's exposed to this either unintentionally or maliciously, you can still see these burns. And you can imagine if these are on the skin, but if this was inside the GI tract as well, it could be quite dangerous. This is a picture from a patient who had ingested hydrochloric acid, and you can see just sort of this black discoloration, this coagulative necrosis that's occurring on some of this resected part of the intestines here, that this black color showing that necrosis. So the burn can be quite severe. Again, we think about a lot of these acids being corrosive to the skin, but keep in mind that if it's corrosive to your skin and then you ingest it, that corrosiveness, just because you don't see it on the skin doesn't mean it's not happening. I will also mention that we talked about hydrochloric acid earlier as a gas, but here we're talking about it as a liquid. So hydrochloric acid can exist in either state. Usually we think about it depending chemically, it depends on the temperature, pressure, concentration of the agent. But in general, when hydrochloric acid is dissolved in water, it can exist as a liquid. But when you have pure hydrochloric acid and you expose it to air, it generates a vapor. So it can depend. So, but you can see both of which are not good. This is a patient who is exposed to nitric acid, and nitric acid is used, or we see it from like exhaust fumes and when you're burning different organic nitrogen-containing compounds. The unique thing about nitric acid, it has this like yellowish hue to the burns, and you can hopefully you can appreciate that on your screens, that sort of yellow discoloration we can see on some of these burns. And then lastly, hydrofluoric acid. So hydrofluoric acid is a component of things like rust remover, and it can cause significant burns. This picture you see of the hand here, that sort of white discoloration to the finger, is sort of a classic picture. It can seem benign at first, but then the burn will evolve and it can be quite dangerous, especially, if someone gets it on their finger, that's, something that can be managed to do. But if you get it splashed onto your face, or if there's an ingestion, the corrosive effects of the hydrofluoric acid combined with some of the local effects that it can cause, either at the site or throughout the body, something called hypocalcemia, can be very, very dangerous. So these patients can have not just extensive burns, but can also have life-threatening EKG changes. Particularly a dangerous one is hydrofluoric acid. And so when we think about the treatment for these corrosive acids, it's again decontamination, so getting the patient away from the exposure. If it's on their clothes or their skin, taking off the clothes, irrigating with copious amounts of water. And then depending on the agent, we may have some sort of an antidotal therapy that we can use. So I mentioned that hydrofluoric acid can cause a hypocalcemia. We can give for patients who have like a local exposure, for example, on the finger, talking about using a calcium gluconate. Usually, sometimes it exists as a gel, like a calcium gluconate gel that we can use for patients who have these burns. So again, it does depend on the agent that's used, but decontamination and supportive care are always going to be the mainstay of therapy here. So that was an overview of 4 different topics. And if you're interested in seeing more like resources and documents on agents like these, if you go to the Region 7 website, which I've put in yellow highlighter here, see on the right side of the screen, you see material guidelines for things like chlorine, cyanide, phosgene, all topics we talked about today. These guidelines exist. And so if you're ever interested in learning or reading more about them, feel free to hop on over to this website and check those out. Okay. Here are my references, and I'm going to pass it over to Ms. Jacobitz, I believe. I think we're going to change the screen sharing to her. So one sec. All right, you should be good to share your screen.
Okay, great. Thank you so much, Dr. Trebach.
Thank
That
you.
was excellent. Let me go ahead and share my screen. Okay, just a thumbs up if you can see it in full screen mode. All right, thank you very much. Okay, so now that we understand some of the chemical threats, we're going to discuss some of the resources. And one of the resources within Region 7 is the Chemical Specialty Team. And the team's primary mission is to assist in the medical management of chemical exposures. And these exposures may be small, they may be more everyday incidents, or they may be very large scale or hazmat type incidents. So you can see some examples of chemical emergencies, but really keep in mind that any time that any assistance is needed, the team is available to provide immediate response, and we'll talk about how that works. So our team in Region 7 consists of the experts that are located in the 4 poison centers. So we're very fortunate that each of our 4 states has a poison center in each of the states, and they're all staffed, very well staffed by medical and clinical toxicologists. We have physicians, pharmacists, and nurses. We also then would supplement, again, we would primarily be focused on medical management. We would rely on the regional hazmat teams, and I'll talk a little bit about the civil support teams as well. And those would be really important partners in any large scale incident. So just real quickly to highlight, so Dr. Trebach's Poison Center, the Iowa Poison Control Center, is located in Sioux City, Iowa. The Missouri Poison Center is located in St. Louis. The Kansas Poison Center is in Kansas City, Kansas. And then our Nebraska Poison Center is located in Omaha. And so when we set this up, we really wanted to make sure that activation of the team is very simple. We put this team together recognizing that many of these functions are done or provided by poison control centers, and they're not only in our region. And so poison control centers are 55 poison centers in the United States, and each of those centers has the capability to provide assistance following chemical exposures. But if you happen to be in Iowa, Kansas, Missouri, or Nebraska, you're going to call the National Poison Helpline. Really, just like anywhere else in the United States, this number is nationwide. And occasionally there are routing glitches, but most of the time when you call, it's going to route callers to the poison center that is designated to serve your state. And if there is a routing issue, we work together all of the time and we can get you to the correct poison center. So again, even if you're outside of Region 7, you can still call this number. You'll be routed to your center. And all centers have the expertise to provide some immediate assistance following the chemical exposures. It's just that we partnered together and we're working as a team, particularly for the larger scale incidents. We would have a lot of support. And so how does our team work? Well, one of the things that we would immediately provide is going to be this immediate telephone advice. And, we're available 24/7. We have, as I mentioned, all those experts, and we could immediately assist you with that. In a larger event, then we would recruit additional members of our team and work together so that we could quickly initiate some telemedicine consultations. And we did no notice exercise a while back, and had very, very great, almost immediate response from all of our team members in the 4 poison centers who said yes, it would be available to help right away. And if needed, our team could also travel to the scene of a disaster. So again, much of this assistance you see on this slide in terms of the response and how the team can help is going to be provided by all poison centers. And so regardless of who you contact, you're going to get expert assistance. And so one of the things is, to identify what potentially you might be dealing with. Often the types of chemicals involved in an exposure can be unknown, particularly initially. And so our staff can assist with, based on symptoms. Dr. Trebach did a great job of talking about some of the different toxidromes and how, we can identify symptoms based, or the chemicals based upon exposure to groupings of symptoms. Also, of course, the scenario, if it's a chemical plant that released a chemical or there was a fire, then, what types of chemicals were manufactured, or what were they used for, and we can help identify. Also, just then assessing potential toxicity, dangers to first responders. We would assist with the triage, provide recommendations for decon, and then provide treatment recommendations. And those really fall into two categories. If we know of specific patients that we are contacted about, we refer them in, or the hospitals contact us about chemically exposed patients, then we're going to customize the treatment recommendations specifically for those patients. If it's broader, we will put out a broad notification as well, so that all hospitals in the area, public health, and other partners are aware of the situation, and we will attach some information. So if we happen to mention, we have, for instance, for example, with irritant gases, if there would be a chlorine gas release, we happen to have a clinical guideline that we could attach. And then lastly, we would get very involved with assisting with locating and transferring some antidotes. And speaking of guidelines, our team has developed some regional hazmat guidelines, and these are located on the team's website. And you can see 10 of them listed there. These are truly regional in that, we had specifically Dr. Dan McCabe, who's the medical director of the Iowa Poison Control Center, and he has done a great deal of work on getting these from older guidelines. They've been revised, they've been updated. They're truly regional because we then have sent these guidelines to all of the leaders of the 4 poison centers. We've asked, do they have any guidelines, clinical guidelines on these topics? We tried to make sure that we incorporated everything. So it's a regional approach. I think the nice thing about these guidelines too is that they all have a similar format. And so, for instance, they all have sections on PPE for the decon team, plus the PPE for the treatment team, also decontamination of victims, signs and symptoms, and treatment. So they all follow that same format. They're more detailed and patient specific than some of the things that we had found online. And so we have new ones coming. We have 10 additional guidelines that are currently under development in various stages of review. And so I think these guidelines are going to be really helpful as well. Exposures to some of these chemicals are relatively rare, but in that case, it's really important to have immediate access to these guidelines rather than, in a situation where we have an incident and it's a more rare chemical where our poison centers don't have guidelines available. Then what we're doing in response is quickly developing some sort of a guideline. And this, if we have these available, of course, then we don't have to scramble and develop something. And they're available out there. They will be available as soon as they're finalized. This is another resource that maybe some of you've seen, but this resource was produced a number of years ago by the Omaha Metropolitan Healthcare Coalition Pharmacy Work Group, which I chair. And then in conjunction with our Poison Center, we developed, it's a 2-sided, we print these off often as a laminated card, and it does provide an overview of chemical, biological, radiation agents, and we've got them grouped by category. And we do update this, try to update it every 2 years and reviewed. And so then this side contains the pharmaceutical treatment information. And there's a thing to remember here is I think it's a nice high-level overview type resource available on the chemical team site and also nebraskapoison.com on our Poison Center site. But always think about contacting the Poison Center for patient-specific treatment recommendations. And then again, we can also assist with locating antidotes and other types of disaster medications. Also, here's just another example of a resource that our team developed. And this is a smaller pocket size EMS, one of the smaller guide that was they could keep on their squads and utilize that. So that one's available as well. And then recently, our center recently updated its recommendations for antidote stocking for hospitals. And this one is available as a printed poster, as well as being on the website. And then just a little bit about CHEMPACKs. So CHEMPACKs are an important resource for responding to the organophosphate insecticides and other nerve agent exposures, which, as you recall, Dr. Trebach discussed this as the cholinergic toxidrome. So these are forward deployed assets. They're located in every state, and the number of CHEMPACKs is population based. So for example, in the state of Nebraska, we have 12 CHEMPACKs that are spread out throughout the state. The higher population states have many more. And some of these Dr. Trebach showed you, but each CHEMPACK contains antidotes in both the form of auto-injectors and vials. Auto-injectors more commonly being used in the pre-hospital setting, whereas vials are primarily used in the hospital setting. And so ASPR is the agency that oversees the CHEMPACK program. And as you can see, because these antidotes must be administered quickly, the CHEMPACK team does maintain many, many containers and in many locations in the United States. And the nice thing about the CHEMPACK is that more than 90% of the US population is within an hour of a CHEMPACK location. And most of these CHEMPACKs are located either in hospitals or in fire stations. And so again, they can be quickly accessed. There are 3 types of containers. Traditionally, there were 2 types. There was the hospital container, the EMS container, and that's most commonly still what is used. The hospital CHEMPACKs are, again, about 85% or the majority are vials. They do although contain some auto-injectors. And on the picture here, which is a couple of CHEMPACKs in Nebraska, the one on the right with more boxes is a hospital CHEMPACK. It has enough medications to treat an average of about 1,000 victims of nerve agent exposure. The EMS CHEMPACK shown there on the left is primarily auto-injectors with some vials as well and can treat an average of about 454 patients. And then the newer option is the WMD containers. And what they've done there is they've basically taken the contents of 2 EMS containers, combined them into 1 container. According to ASPR, they haven't received additional resources, but places that have elected to do this just felt like they wanted more resources in the 1 container, partly because there are ways now to mobilize resources and move them if there would be a large-scale event where you would want a CHEMPACK temporarily near the event. And these are always temperature controlled and kept in secure locations. And so again, since this is about our region here, Region 7, I've included how you can request CHEMPACK resources. Most of the time it's through your Strategic National Stockpile Coordinator at your state health department. In Nebraska, you can also call 24/7 our Poison Center, and we can assist with getting the ball rolling. And we work closely with Nebraska Department of Health and Human Services. Just a quick mention about the civil support teams, another awesome resource. There is one located in each state. These are National Guard assets, and deployment is controlled by emergency management, state governors. Typically, the way it works is if there's an incident, then the incident commander on the scene can go ahead and make the request through state emergency management agencies. And they have a number of resources. I've been fortunate enough to be able to go to Lincoln, where our 72nd CST is located, and they have a great deal of expertise. These team members could help with decon. They could help with providing advice. They can help with, they have mobile lab where they can assist with chemical substance identification, communications, and they're an awesome team. And then lastly, I just want to, again, put a plug in for the Advanced Hazmat Life Support courses. If you're interested in learning more about the medical management of chemical and other hazardous material exposures, I really encourage you to register for one of these AHLS courses. We are offering one in each of the 4 Region 7 states this year. And if you do live or work within Region 7, you can attend these courses. There's no charge. If you're outside of Region 7, you also can register, and then you would pay a tuition fee. But either way, if you go to ahls.org, then you can see not only the courses I have listed here that we are offering, but you can also see what's being offered not only through the US, but even in other countries as well. So it's a 2-day provider course, and then there's an additional half-day instructor course for people who would like to teach. All righty. Thank you very much. And at this point, we're going to open it up for questions.
Great. Thank you, Kathy and Dr. Trebach. A great presentation as always. So we do have a couple of questions in the chat. Dr. Trebach, we'll start with you. So I see in the photo the atropine is IM auto-injector. Is there a preference in giving atropine IM versus IVP?
Sure. Thank you. So I think in a perfect world, you could give things IV. However, the reason the auto-injector exists and the reason it's IM is because oftentimes if you are treating multiple patients or treating a patient who is very cholinergic and is having a lot of diaphoresis and fluids, and it's sometimes really hard to get IV access on these patients, and sometimes your IV will just fall straight out. So in a perfect world, if you can give it IV, sure, but IM, especially when you're treating large amounts of people who could be exposed, especially in a disaster scenario, is fine as well.
Great, thank you. Let's see. Kathy, there was a question about, do the packs include, so the CHEMPACKs include information about how to treat children?
So that's an excellent question. If there's information there, it's possible that each state has provided some informational resources. They certainly, though, the CHEMPACKs do have medications that can be used to treat children. There are some there are vials which you could individualize the dosing of the atropine and pralidoxime and other medications specifically for the child's weight. There are also some auto-injectors. There are some atropine auto-injectors called atropins that are available in the CHEMPACK at a lower strength than what you would give an adult. So certainly, yes, they have resources for children as well.
Thanks, Kathy. Good question. Dr. Trebach, you mentioned using a non-rebreather. Would it be additional advantage to use CPAP with 100% O2 for high CO levels in the pre-hospital setting?
That's a really fun question. I really like whoever asked that question. That's very cool. So I will say that the short answer is that makes some sense, right? So I'd say that it has been studied, but the short answer is it makes sense, but we're not entirely sure. The slightly longer answer would be this has been studied, actually. People have done some studies. Again, we don't have any super duper large scale randomized control trials or anything like that, but we do have studies of people who are looking at using CPAP, and it seems to work. Again, I think what we usually rely on is in the transport setting, like 100% non-rebreather. I don't think using CPAP would be unreasonable or inappropriate, but I also wouldn't say, oh, like the patient can only be picked up by a rig that has CPAP. No. Oftentimes, people sometimes have difficulty tolerating CPAP or BiPAP unless they're used to it as well. So again, I'd rather the person get the oxygen first and foremost. So it is reasonable to do if the patient can tolerate it. But again, it's not the sort of standard recommendation, but it is an area that is being studied. There's some interesting papers.
Interesting. Yeah, I think
Yeah,
CPAP
cool.
is dependent on patient tolerance for sure.
Yeah.
Let's see, another question in the chat. What is hydrofluoric acid used in?
Oh yeah, so hydrofluoric acid's used a lot of it's used in the manufacturing process for making like refrigerants, but it's also used in fluorescent light bulbs. What else comes to mind? Um, Aluminum, plastics, some electrical components. But yeah, I think a lot of it's for like refrigerants. I think some uh, high octane gasoline maybe. But
Is there
yeah,
a lot of workplace injuries involving that?
you know what? It depends. Sometimes a lot of the workplace injuries are someone was exposed to something. What could it be? So it certainly
Yeah,
depends.
mystery.
Yeah.
Let's see here, Kathy. When you send out the larger notifications, who and how would you send it through? And is it through a healthcare coalition or directly to the individuals?
That is an excellent question as well. Um, I would say it depends on the location for at least our poison center of the incident. Certainly through our Omaha Metropolitan Healthcare Coalition, we would send it out. Actually, we have two ways to get it out. We're either going to blast, fax it out, or email it out. The hospitals, actually in our whole service area, still like us to send them information on maybe the old-fashioned fax machines. We don't have to keep track of, emails and all of that. We can immediately get them some information. So that is one way we do it. We blast it out, and it would go to any hospital, either of the city where the event occurred, or town, or rural area, or surrounding hospitals where we were concerned that, somebody might walk in, they need to be aware of it, or if it become a larger incident, then let's make them all aware of it. So also added on to that, we also have our state, Nebraska Public Health Lab had requested to be on that notification. And we also send it out to not only the state health department, but the local health departments that would be in that area as well. The other way we can get it out, and we would get it out both ways, and we have with incidents, has been through the email list that we have through the Omaha Healthcare Coalition. It gets emailed to everybody who would be on the list who would want to receive that notification. Do we have that set with all of the ACCs in our area? No, but we should. That would be the next step, where we could work with them. And if they have an email address that we could send something out on, then that would be a quicker way to do it. So great question.
Yeah, thanks, Kathy. I'm not seeing any more questions, so if there's any further questions, please feel free to drop them in the Q&A. But in the chat, we did put the link to where the CBRN quick reference guides and posters are available to print from our website. And then also the chemical guidelines that both Dr. Trebach and Kathy talked about are available for print on our website as well. And we expect to have more of those out later on this summer. So we appreciate your time today and attending today's webinar. The website for your CE and activity code is in the chat as well, and the recording and slides will be available within 3 to 5 business days. So thank you to you both for presenting today, and thank you for everyone who attended. We appreciate it. Have a great day.
Thank you.